morning, everyone. Here we are again come to explain about the diastolic dysfunction via the TE. It is a continuation of the TE series in which we are going to discuss about this topic. Why we discuss about the diastolic dysfunction? Why we study it? Actually, this diastolic dysfunction is going to predict outcome. There are many articles which shows if we diagnose the diastolic dysfunction very early, we can predict the outcome. And if we predict it, then if it can be improved if we diagnose early by treating it. So how we diagnose it, we will see in the clinically or echocardiographically. I divide my topic in following heads: anat, orientation of the myocardial fibers, physiology, pathophysiology, clinical importance, causes, phases of the diastole and the T evaluation, and lastly algorithm of the diastolic dysfunction to diagnose. Here there is a topic which shows diastolic dysfunction actually affect long-term and short-term outcomes. This study is the actually 8,000 done in the 8,000 patient and coronary and the valvular surgeries, and which shows diastolic dysfunction associated with the poor and long-term outcome. Same, there is a second study which shows in 180 patient, it shows that if the diastolic dysfunction increases, the total cumulative death is increased. So grade 1 has a minimal death or minimal death as compared to grade 3. This one. Same, another study which shows there's a percentage of survival almost 100% if the patient with normal LV, approximate. And if thus asymptomatic isolate diastolic dysfunction is present, survival rate will decrease over a period of the time. And if asymptomatic systolic dysfunction, the survival will further decrease. And if the patient is in heart failure, the survival rate is already less over a period of the time. So actually, from this diagram, we can see the mortality or survival rate is higher in heart failure as compared to systolic and then diastolic failure. But still, if diastolic dysfunction have some mortality rate, and if we diagnose early and we can treat and we increase our survival in the patient. So this is the actually 4 predictors in TE or in echo, which are now considered as good for the diagnosis of the diastolic dysfunction. First is E by E prime, LA volume index, and TRV max, and lastly E prime velocity. We will see in the transesophageal echocardiography. Now the anatomy in the heart muscle, we will see the fiber arrangement here. This is the 3 layer in the LV. Deep layer is a longitudinal muscle fibers, and middle layer is a radial fibers, and outer layer is a circumferential fiber. And this is the atrial musculature, which shows the constrictor muscles in the atria, and this is the arrangement of the fibers in the ventricle. See, this is we see Purkinje fiber is just below the endocardium and subendocardium. In between there is a Purkinje fiber. It means the contraction start from here and then goes up to the epicardium. So helical, the arrangement of the fiber in this endocardium and the ectocardium is epicardium is actually different. This endocardium, we will see in the next diagram. This is a diagram which shows endocardium fiber is the longitudinal, mid is radial, and epicardium is circumferential. And similarly in systole and diastole, the contraction of the LV muscle or fibers is shown like this. During the shortening means contraction of systole, this annulus or fiber moves downward, and during diastole it moves upward. Same thing we see in the echo, where the velocities move according to this movement. Second, mid wall is moved radially inside and outside during the systole and the diastole. And same circumferential shortening agar it is clockwise during the systole and anti-clockwise during the systole and the clockwise in the diastole. So what happened during the systole? Actually, the electrical activation initiated in the endocardial Purkinje fibers. It shortens the endocardial fiber wrap in the right-handed helix. Means the endocardium moves in right-handed helix and the ectocardium or epicardium moves the left-handed helix. It will squeeze the whole LV during the systole. During the ejection phase, the electrical activation reaches at the epicardium and shortens the epicardial wrap fibers in the opposite direction. It is a left-handed helix. So epicardium fiber is a left-handed helix and the right-handed helix are the endocardial fiber. In next time it is clearly seen, this is the endocardium and fiber element in the right-sided helix, and this is epicardium and fiber arrangement in the left-handed helix. This is a diagram figure which shows it. The fiber arrangement and contraction during the systole and the diastole. See the arrangement. Here these fibers are the left-handed helix and here the right-handed helix. Contraction is occur just like this. And why we study? Actually, own studies shows that there is a 65% mortality rate in patient with discharge from the hospital and having diastolic dysfunction within 5 years. Means the mortality rate is associated with the diastolic heart failure is still very high, 65% within 5 years from hospital discharge. So, but still we can say the during systolic failure and the diastolic failure, the mortality rate is higher in the systolic failure. It is 13% in the rich studies and approximate 11% in the diastolic failure. Third is Redfield is at all showed almost 80% patient have the diastolic dysfunction with EF 50% or less, and the adhere acute decompensated heart failure registry shows diastolic heart failure is common in the older patient, women, hypertension, diabetes mellitus, and the atrial fibrillation. So what happened in the diastole? Actually, during the systole, the calcium is flooded inside the cytosol, which causes calcium attachment on the troponin C and causes contraction of the heart muscle, actin and myosin filament. And after the systole, the diastole occurs. This then what happened? This phospholamine is phosphorylated by ATP. It is ATP induced and the phosphorylation of the phospholamine, which causes the calcium sequestration inside the sarcoplasmic reticulum. And secondly, this sodium and the calcium oxygenation will also decrease the calcium level from the cytosol and also inside the mitochondria. Means removal of the calcium from the cytosol inside the sarcoplasmic reticulum or outside all the mitochondria causes diastole. And rapidity of removal of calcium from the cytosol leads the lusitrophy effect of the any drugs, and depending upon how fast this calcium goes inside the or removed from the cytosol. This is the 4 phases of the diastoles. First is isovolumetric relaxation. From it is start from the A2, means opening of the closing of the aortic wall and opening of the mitral wall. Second phase is early diastolic filling, in which there is a 80% filling occur, and it is shown in the echo as a E wave. 80% filling occur. It is mostly due to the LV suction. What is LV suction actually? Normally, what happens when the basal part is relaxed, the suction pressure is same in whole LV. 4 mmHg, 4 mm. Just take an example: 4 mm and 4 mm in normal relaxation. But if the LV is ballooned, or you can say the diastolic dysfunction, then what happened? The basal gradient is 4 mmHg, but the apical or as they go down, it was approximately 1 mmHg. What happened? There is a gradient occurs at the basal, or you can say basal and the apical. So inside the LV, there is a gradient occur if there is a abnormal relaxation, which is diagnosed in the echo also by the mitral valve inflow propagation velocity we will discuss. And third is diastasis. It is only seen with the heart is less than 70. We can see there is this phase. There is a no flow occur from LA to LV. This is called as diastasis. And lastly, there is a atrial flow, atrial systole, which is shown by the A wave, and it is close to 20% filling of the LV. And then after there is a isovolumetric contraction time. This is IVRT, IVCT, diastasis, and this E wave and the A wave in the echo. Second, if we discuss about the physiology, then what happened? This is a whole systole phase and this is the diastole phase. What happened in the aortic patients, LV and LA patients, and the echo and the ECG? See, the systole occurs after the QRS complex till the T wave. This is the aortic wall open and systole occur, and here aortic wall close. Since after closing of the aortic wall or A2 occur, the mitral valve will open here, and the suction pressure of the LV is decreased. The LV pressure inside more than the LA leads to suction of the create the suction pressure, and which create a gradient between the LA and the LV. This is the LA pressure. Here the mitral valve will open. So what happens? This is the gradient occurs between the LA and LV, and this leads to E wave. Here we can see the E wave occur due to this gradient between the LA and the LV. And after that, the equilibrium occur because the pressure inside the LA and the LV become equal. There is no flow across the wall, and then due to the atrial contraction, there is again 20% flow occur. It is shown in the as a E wave in the echo. And ECG, it is from the T wave to the just about, before the QRS complex. Intervertebral relaxation, early filling, diastasis, and the late atrial filling. It is as shown figure. Similarly, in the pulmonary vein, we will see the S wave occur in the systolic phase and the D wave occur in the diastolic phase. And after atrial contraction, the atrial reversal will occur during the atrial A wave, atrial systole. So this A wave and this is a atrial reversal wave, and this is a A wave. So we can also focus on this also when we are discussing about the diastolic dysfunction. We will see what is the causes of the diastolic dysfunction, which is shown by the adhered study. These are the obesity, hypertension, aging, heart failure with the reduced ejection fraction, dilated cardiomyopathy, recessive cardiomyopathy, and hypertrophic cardiomyopathy, and coronary artery disease, Marfan disease, and LBB or the patient can lead to the diastolic dysfunction. If we discuss about the pathophysiology, either patient or overload because of hypertension, AS and all, ischemia, CAD, or because of hypertrophy or muscular infarction, myocardial infarction, all leads to abnormal relaxation and the stiffness of the LV wall, which causes elevated LV filling pressure, and that elevated filling pressure and LA encounter the high LV filling pressure, so the LA pressure will increase, and over a period of time the size of the LA also increase, which leads to the atrial fibrillation and decrease the cardiac output and decrease the exercise tolerance and leads to diastolic heart failure. Sometimes due to the LV filling pressure, the pulmonary blood pressure also increase and during the exercise, which decrease the exercise tolerance and leads to diastolic dysfunction. But sometimes the abnormal filling is there, but is a normal exercise tolerance, means it is a masked diastolic abnormality is also there in some patients. So we have to know about these. Now we discuss about the echocardiographic evaluation of the diastolic dysfunction. You just know about that there are some load independent indices and some other load dependent indices. So our main focus on the load independent indices like mitral angular tissue velocity, E wave propagation velocity, or load dependent. In load dependent, we see LS size or transmitral velocity and the dislocation time, and pulmonary vein velocity. This is the CAS diagram showing the LA pressure and the LV pressure by the purple line, and this is the mean LA pressure, and this is the same thing. Mitral aortic wall is open here, mitral wall is closed here, mitral wall is open here. To the suction of the LV, this gradient create between the LA and the LV, it leads to the E wave in the echo, and further there is the equilibrium of the LA and the LV. There is a diastasis phase, and after that the atrial contraction occur. This again gradient is created, which leads to the A wave, and after the A wave, this is the LVEDP. Now many studies says elevated filling pressure means pulmonary capillary wedge pressure is more than 12 or the LVDP is more than 15 or 16, you can say. Then discuss about the transmitral flow velocity in the TEA. In TE, the LA is above and the LV is down, as it is just opposite as the transthoracic echo. So what happened if we put the sample volume of 5 mm across the mitral wall leaflet tip? What happened? There is an inflow which is showing downward, means away from the probe. So we see the velocities below the baseline. So in mid-esophageal 4-chamber and long axis view, mid-esophageal long axis view, we can put the pulse wave Doppler and find the peak of the E wave, and this is the decision time from this peak to just an baseline, and this is a diastolic stage. After that there is a A wave, and this is a peak of the A wave velocity, and this is A wave duration. What parameter we get from this? E wave duration time, A wave, and the A wave duration. We will discuss each what is E wave, how it, what A wave and all. E waves actually depend on the LA pressure and the compliance of the LA and LV, resting LV diastolic pressure, and the suction force generated by the relaxing LV. And decision time is approximately 160 to 150 millisecond. And after early filling and generation of the peak E wave, a decision time occur as the velocity decreases toward the baseline. Reduced compliance leads to the rapid equilibration of the pressure gradient between the LA and the LV, resulting in the shortened decision time. Therefore, decision time is considered as a good surrogate for the LV compliance, but it is also a dependent indices, not the independent indices. It will change with the preload and afterload also. Same thing for IVRT. If the LV is relaxing very poorly, then IVRT will prolong. And cutoff is 75 milliseconds, and some studies shows it will predict the elevated pulmonary artery systolic pressure approximate 94 to 97% sensitive, and specific approximate 94% sensitive. Sometimes we can see the LV is present in this stage. In diastolic pressure, the LV is present like this. It is more than 20 years, it is abnormal sometimes. LV present is called as, it is a, if present, it is a pathognomic. You can say LV is encountered in the individual with the delayed relaxation and the increased LV stiffness, but it is sometimes present, not always. A wave is the A wave velocity depending on the atrial contractility. With early diastolic dysfunction, the A wave predominates and exceed the E wave velocity in gate first, or you can say gate 2. The E wave velocity increase because of LV is stiffness, the suction effect will decrease. So E wave is decreased and A wave increase. But over a period of time, what happened? The A wave velocity become less as LV complies worse, and the LA pressure rise, and the A wave velocity become less than the E wave velocity, again reflecting the inability of the LA to fill the non-compliant and the full LV. And this is a E by A ratio of the velocities, which shows that we can grade depending upon the E by A ratio. So we can see in the algorithm also, and it is measured only during the apnea, because ventilation is spontaneous or controlled alter the preload by changing the intrathoracic pressure during the respiratory cycle. So what happened? Actually, it is the load dependent indices. That is why if we change the preload or afterload, why we give the NTG of inadequate, the velocity, E wave, A wave, and the ratio is changed. That is why we will measure in the apnea. It is not reliable in the tachycardia, or you can say we increase the preload value if we give the volume, and also in the AF, because there is no A wave and because no sense, it is only diagnosed in the sinus rhythm. Mitral regurgitation also increase the flow. Because of the mitral regurgitation, the LA volume will increase, and further it will come into the LV, the E velocity will increase, same as the MS. Because increase E wave and A wave velocity, and it is merged, and increase the decision time, reflecting the stenotic wall rather than the LV pressure. Severe acute aortic insufficiency means if the AR is there, the LV filling pressure is already high, it will decrease the E wave and the A wave. And these are the limitations. Same what I told you already. It is a load dependent indices. That is why it is change in the coronary artery disease with poor LV filling pressure. Also is challenging in the arrhythmias and altered by the LV volume and the elastic recoil. It is also age dependent. It is will decrease over the age because LV stiffness is increased during the age. After 40, you can say. In A wave velocity, it is also only measured in the sinus tachycardia, but it is sinus rhythm, but not in the sinus tachycardia. or if the block is there, then we can measure the AV velocity, and it is not applicable in the AF or atrial flutter patient, and it is also A dependent. Same thing, E by A ratio, it is a U-shaped relationship, because as the starting the E wave is normal, but over a period of time, the E wave again increases. So over a period of time, in old ages, then the E wave, because of this diastolic dysfunction, you can say the increased stiffness of the LV, this U pattern, U-shaped relationship occur between the LV diastolic function, make it difficult to differentiate from the normal and the abnormal feeling patients. If the mitral velocity at the start of the atrial contraction is more than 20 centimeter, then E by A ratio will be reduced due to the fusion of the E and A. That is, it also is not applicable in the AF and the atrial flutter, and is also the dependent. Second is the mitral annular tissue velocity, and this velocity is a independent indices. It is not affected by the preload or the afterload. It is well seen in the midesophageal 4-chamber view. This is the LA, this is LV, and this is the septal wall, and you can say this is the lateral wall. What happens if we put this sample volume of 5 mm at just basal part of the LV? What happens during the systole? It will goes down, and in the diastole it will goes up. So during the systole it will goes down. This creates the S wave, systolic wave, and in the diastole if it goes toward the probe above the baseline, E prime and the A prime will see. Here we measure the E prime and the A prime and the S prime. And this is a biphasic contraction, or you can say biphasic wave, which shows the IV RT and IVCT in isovolumetric reduction time and isovolumetric contraction time. And it is a biphasic due to the gradient between the LV basal and the apical part. It is biphasic. So we measure all these 4 parameters and will grade diastolic dysfunction according to this. We see the E wave E prime is rapidity, shows the rapidity of the LV relaxation and the elastic recoil of the LV, and it is less than 8 mm diastolic dysfunction. If there is a atrial contraction, it's shown by the A prime. It shows the LA function or the LA contractility or the LV EVP. Same thing, S prime or systolic wave shows the movement toward the apex during the systole. And this IVRT and IVCT are the end of the S wave and the beginning of the E prime. Is a biphasic signal because of the apex to base gradient in the relaxation time. Here septal E prime and the septal, always the septal E prime is more as compared to, lateral E prime is more as compared to septal E prime. Okay. And if there somebody studies shows that the E and E prime is more than 15, it will predict the high filling pressure, and if it is less than 8, it shows a normal filling pressure. But if there is a mitral annular calcification is there, MS is there, or the positive wall is there, is this decrease the E prime, then this ratio is not applicable in these kind of pathologies. Since third is, you can say mitral valve propagation velocity it is also a load independent indices, and it will occur because of the gradient across the basal and the apical part. As we show, LV section effect, this is the main responsible for the mitral valve propagation velocity. If in midesophageal 4-chamber and we put the color and also the M mode over the apical, you can say basal, you can say at the tip of the mitral valve, what we see, there is a turbulence occur because of the gas gradient from the basal and the apex. There is a gradient being diastolic dysfunction. This turbulence of, you can say, E wave shows when we measure this caliper, and we measure the slope caliper and TEE, and we find if the propagation velocity is less than 45 centimeter per second, reflect the impaired relaxations. And this E prime, this is minor studies is also done where it shares if it is not this is normal if it is more than 50 centimeter per second, but if it is less than 40, it will predict inotropic requirement after the aortic wall replacement in ES. And some author shows A divided by V propagation velocity ratio, it is more than 2.5, then it predict the pulmonary artery wedge pressure more than 50 Hg. But if the AR is there, or then we AR interfere the in the propagation velocity because of this flow of the because of aortic decretion flow during the diastole. And it will not grade. We cannot grade depending upon this velocity, but we just tell this diastolic dysfunction is present or not. We just, as it is an adjunct, we can say if diastolic dysfunction is there or not. We not grade according to the population velocity. Third is, next is pulmonary venous flow, which as shown in the pathophysiology, S wave and the D wave is present during the whole cardiac cycle. The D wave is actually in the diastolic phase. What happened? The peak systolic wave velocity S wave and the D wave, and we calculate the SD ratio. And secondary measurement, these are the primary measurement. And secondary measurements are the atrial reversal wave duration, AR duration, or you can say difference of the AR duration and the mitral A wave duration, and the distribution of the D wave. Here we see, if we put the pulmonary venous Doppler, pulse wave Doppler in the pulmonary, 1 centimeter inside the pulmonary vein, you can find the systolic S wave, diastolic D wave, and then the atrial reversal. See what happened if this is during the contraction of systolic phase, and this is during the diastolic phase. And if there is a when LA contract, what happened? When LA contract, it will flow. It will cause the flowing of the blood from the LA to LV. But LV if poor, or you can say diastolic dysfunction is there, or LV is very stiff, what happened? The blood in the LV, the blood in the LA not going inside the LV, it goes inside the pulmonary vein because it is a wall-less, and that is represented by the AR, and with the velocity is increased and the time duration of the AR also increased. See, the time duration and the velocity is increased if the LA is not able to pump the blood into the LV. Instead of that, it will pump into the pulmonary vein. We can see pulmonary vein is easily seen in the mid-esophageal view above the ligament of the Marshall and at 90 or 45 or 90 degrees better seen. It is just below the just behind the ligament of Marshall common ridge. This is the red flow because it's toward the probe, and we put the 1 centimeter inside the pulmonary vein. We will put the pulse field Doppler in this side. We can see this diagram. And same for the right side, it is a atrial septum. This is SVC, and this is the just the SVC. We can see the right upper pulmonary vein is blood flow toward the probe. And if sometime we can see SVC type AC is also present over the here, and we can see this flow, blood flow from this pulmonary vein over the RA. Let me close this. Next is TR systolic jet velocity, or TRG max. You can say it is also seen better in the mid-esophageal 4-chamber bicaval modified bicaval view. We adjust the gain and contrast to display the complete spectral envelope. We put the continuous wave Doppler, and we see the complete TR envelope, and without signal spike or filtering. Peak modal velocity during the systole at leading edge of the spectral waveform, and in the absence of pulmonary disease, the increased systolic PA pressure suggests the LA pressures. If the pulmonary disease is not there, means if the lung is normal, then only this TRG max, or you can say increased pulmonary systolic pressure, will suggest the increased left atrial pressure. And the limitation is because it is the indirect estimate of the LAP, left atrial pressure, and also with the severe TR and low systolic RV to RA pressure gradient, accuracy of the calculation is dependent on the reliable estimation of the RA systolic pressure. Here, lastly, the LA volume index, you will see the LA volume reflect the cumulative effect of the increased LV filling pressure over time, or they can say increased LA volume in an independent predictor of death, heart failure, AF, and ischemic stroke. It is very difficult to access the whole LA in the mid-esophageal 4-chamber view. But some studies are showing that if we do the disc or the area length method and correct it for the BSA, and do not include the LA appendage or the pulmonary vein during the LA tracing, and all in the apical 4-chamber or the apical 2-chamber view in the transposition, not in the T. In D, actually, what happened in TE? What happened? We will show is in diagram. But first we see is to limit patient because of LA dilation, which is seen in the bradycardia or high cardiac output state or heart transplant with the biatrial technique, atrial flutter fibrillation, significant mitral valve diseases, or despite the normal LV function, this is not a good parameter, LA volume index in these diseases. Or you can say in LA dilation also occur in the built-in athlete because they having the bradycardia. Means if there is a LA dilation in the normal patient also sometime occur, but this is normal. We are not great diastolic dysfunction in these patients. There is a suboptimal image quality, including the LA foreshortening in technically challenging in studies, precludes accurate tracing. And it can be difficult to measure the LA volume in patients with ascending and descending aortic aneurysm as well as in patients with a large intra-atrial septal aneurysm. What happens is that many studies which shows that can we measure the LA atrial size accurately on transesophageal echocardiography as compared to the transthoracic. So there is a study done in the 57 patient where compare the transesophageal versus the transthoracic echo, and which shows the both atria chamber diameter and the volume are underestimated on the transesophageal echocardiography. That is why it is not a good indicator of the marker in the for the transesophageal echo. So this study also shows if we see the LA diameter, or we can say it is just mostly equal, means LA diameter we can accurately define in transthoracic and transesophageal and transthoracic echo. But if we consider it is a spherical, LA is spherical, then volume is 4/3 pi r cube, assuming a spherical shape, then we go with the area length and in transesophageal and transthoracic echo, and we find there is a huge difference, approximate 20%, and approximate in the difference in the transesophageal and the transthoracic echocardiography. And only the Simpson biplane method of the in TOE and the transthoracic echo pitched up just 59 and 60 will approximate, not normal, but a margin of error is less. So in bland Altman analysis of the transesophageal and the transthoracic echo shows only the LA volume calculated by the Simpson method, the difference is less as compared to other, like in this in other method, M mode, AL, in this we can see the huge difference in the transesophageal and transthoracic echo. But Simpson is good, but still, it volume or diameter is underestimated, as it is whole article this shows both diameter and the volume are underestimated. So you cannot measure accurately on, or you can't rely on this LA size in the transesophageal echo. So same thing, LA volume is difficult to access in the 4 chamber, and also if the TR is present, then we can only calculate the TR Gmax. Otherwise, many patients have diastolic dysfunction but didn't have the TR. So this parameter is our limitation. The only two features remains for us in the transesophageal echocardiography are the E by E prime and the E prime. Because only two, because LA volume is difficult to access in 4 chamber because it is not seen, whole LA is not seen in the 4 chamber. And second, if the TR Gmax is not present, these two indices are ruled out. Only this E by E prime and the E prime velocity we have, and depending upon that, we have a proposed algorithm in article. It shows that if we measure the E prime velocity and it is more than 10 centimeter, then it is the zero grade, it is normal. And if it is just less than 10 centimeter per second in the lateral wall, then we calculate the E by E prime, and it is also less than 8 or equal to, it is a grade 1, that's why dysfunction. And if it is a 9 to 12, and it's a grade 2, or you can say pseudo-normal diastolic dysfunction. And lastly, if it is more than 13, then it is a grade 3, a restrictive filling pattern is seen. And this restrictive filling is also grade A and type A and type B. In type A, there is a reversal of the E by A ratio is present, and if this is a fixed, or type B, this is a fixed restrictive filling, that the modality of the restrictive filling restrictive filling in those patients who have the fixed diastolic dysfunction, there is no reversal of the E by A, and in the modality rate is high. So grade 3 have two part A and B also. in which there is a reversal of the diastolic dysfunction, there is a no reversal of the diastolic dysfunction. We can't reverse that diastolic dysfunction in the grade 3 type 3A. The mortality rate is less as compared to the type B. And this is a diagram which shows the event-free survival in the diastolic dysfunction patient is more if there is no diastolic dysfunction, and if the event-free survival is very high, event-free survival and is very less, you can say, in patient with the grade 3 diastolic dysfunction. Next, there is some guidelines. On the basis of that, we will see about diastolic dysfunction, but we can do in the trans-thoracic echo much better as compared to trans-esophageal echo. So it is a patient with normal EF. In normal EF, we measure the whole these 4 parameters: E by E prime, E prime velocity, TI velocity, and the LA volume. Why these 4? Because I showed in this slide, I already shown in the previously, these 4 parameters, E by E prime, LA volume index, LTRG max, and the E prime are the main predictor of the diastolic dysfunction. There is a many studies done on these parameters. That is why we measure the whole these 4 parameters, and if it is less than 50% are positive, it is normal diastolic dysfunction. If 50% are positive, means 2 are positive, and then it is a indeterminate. And if more than 50% are positive, means first 2/3 are positive, then it is a diastolic dysfunction. Second, patient with the depressed LV, if the LV is function is decreased less than 50%, 30% like that, then we measure the E by A prime, E by A ratio. If it is more than 2, then it's directly we grade in the grade 3 diastolic dysfunction. If it is more than 2, but only in patient with the diastolic dysfunction, or you can say decreased LV ejection fraction. And if it is less than 0.08, we can grade them in a normal diastolic dysfunction or the grade 1 diastolic dysfunction. But if its value lies between the 0.8 to 0.8 to 2, then 3 criteria will be further evaluated, that are the E by E prime, TI velocity, and the LI volume index. And on the basis of that, if 2 are negative, then it's a grade 1. If 1 positive, 1 negative, grade 2. And if it's 2 positive, then grade 3, grade 2 diastolic dysfunction. Then in feeling basis also we can see in some specific cardiovascular disease like the hypertrophic cardiomyopathy, in which the 3 E by E prime, LA volume index, peak TRGS is the same, but here the pulmonary vein atrial reversal velocity AR minus A duration of the mitral inflow. If it is more than 30 milliseconds, you can say diastolic dysfunction is present. And it is 50% positive, less than 50% positive, less than 2 or 1 is positive, then we can say grade 1. And what is more than 2 are positive, then it is a grade 2. And if with all these restrictive filling pattern, the E prime is also less, then it is a grade 3 diastolic dysfunction. See here the A wave atrial reversal duration and the A mitral inflow duration is more than 30 milliseconds is the criteria. Here the restrictive cardiomyopathy in the early phases of the restrictive cardiomyopathy patient, in early phases there is a grade 1 and grade 2 diastolic dysfunction may be there, but in later stages in constitutive pericarditis, what happened, the lateral wall of the LV will stick to the pericardium. What happened? And there is a leads to decreased movement of the lateral wall. Normally the lateral wall velocity is very high as compared to the septal wall, but in constitutive pericarditis due to the stick, because of an LV lateral wall is stick with the pericardium, the lateral wall will not move and leads to the increased velocity of the septal wall to compensate the decreased movement of the lateral wall. It is called as annulus reversal and is a characteristic of the constitutive pericarditis. And E by E ratio, prime ratio, not be used for the estimate of the LV filling pressure. But in the advanced disease of the restrictive cardiomyopathy, we can see all the detection time. The E wave is less than 150 milliseconds. Mitral E by A is more than 2.5. IVRT is less than 50 milliseconds, and average E upon A prime is more than 14. And LA volume index is more than 50 ml per meter cube, and normal is 34, and which is actually very high, 50 ml per meter cube per meter square. In patient with the arrhythmia, in patient with the atrial nuclear block and the pace rhythm, in here in the patient with the first degree AV block, the variables used to evaluate the diastolic dysfunction and the filling pressures likely remain valid as long as there is a no fusion of the mitral E wave A velocity. If there is a no fusion of the E wave and the A wave, then all the parameters are the valid. But the accuracy of the mitral annular velocity E by E ratio is less in presence of the LV bundle branch block, because the contraction is not simultaneous in the all LV. And same in the RV patient also, or also patient with received the cardiac desynchronization therapy. In this, there is a E by A parameter ratio is not valid. And if the mitral A velocity is present, then if only mitral A velocity is present, only TR velocity can be used as an indicator of the LV filling pressure. But in the patient of the AF with impaired ejection fraction, the peak acceleration of the rate of the E velocity, IVRT, DT of the pulmonary venous diastolic velocity less than 2 to 20 millisecond, or E upon mitral valve propagation velocity is more than 1.4, septal E by ratio is more than 11, which shows the diastolic dysfunction. And in patient with the heart transplant, what happened? Patient with the preserved ejection fraction and the normal diastolic function commonly have restrictive appearing filling. They normally have restrictive appear filling, but there is no single diastolic parameter appear reliable enough to predict the graft reaction till now. But the pulmonary arterial systolic pressure estimation using the TRZ can help us surrogate measurement of the mean left atrial pressure in absence of the pulmonary disease. If the lungs are clear, lungs are good, then only TRG max can indirectly represent the mean ILA pressure. But in heart transplant patient, as a patient in the failure, we can see the pulmonary PVR is sometimes high as compared to normal patient. So maybe sometimes it's not a good indicator, but this is the only indicator which we have in transplant patient. That will finish my topic. Thank you. Thank you so much.